As we come to the chronic suppressive therapy, we come to the stage that the battle is lost. Is it so? Is there any role of CST? So I consider this patient profile of an 82-year-old gentleman with rheumatoid arthritis, hypertension, diabetes. He's from a poor socioeconomic background. He's already undergone DARE. His EF is very low, and he has no other options left. So in these particular patients, there is still role of chronic suppressive therapy. Now, when we talk of infection control, it is rested on these three pillars. One is decreasing the viral load or the bacterial load, patient's immune response, and the antibacterial or antibiotics that we use. So when we consider stages of periprosthetic infections, it is the perioperative phase, which is the first 72 hours after your surgery or DARE. Then you come to the primary phase, which is 72 to 6 weeks after your DARE's procedure. And then 6 weeks after the DARE is the role of chronic suppressive therapy. So it is this part that we are going to talk about. That means that chronic suppressive therapy cannot replace the other two, as we mentioned earlier. So the definition of chronic suppressive therapy is administration of antibiotics for a long-term or indefinite period. It's non-curative as a strategy. Antibiotics that are provided here are beyond 6 weeks that we're talking about. And usually they are after a DARE procedure and they are considering oral antibiotics. Do we have options? We'll see that further. So indications again are patients over 80 years of age with unacceptable anticipated functional outcomes after repeated debridements. They cannot undergo repeated surgical procedures. They have other conditions that prelude or prevent further procedures, short life expectancy, major surgical contraindications, and patient's refusal for any kind of surgical debridement. What are the bugs that we have found? 52% have staphylococcal infections, 8% are streptococcal, 10% being gram-negative, and 5% being infections with enterococci, 1 patient with diphtheroids, and 24% are the culture-negative infections. Outcome measures, very difficult to predict with CST. They include avoiding further surgeries, implant retention as we've discussed earlier, prevention of relapse or reinfection, appearance or prevention of appearance of a fistula or healing of a fistula, and development of a tract that usually happens within 3 months of index debridement or death as an outcome. So antibiotic selection, these are the guidelines. These may not be suiting your antibiogram, but by and large, in the first 72 hours of DARES, we use vancomycin and cefazolin. In the primary treatment, we use vancomycin, rifampicin, cefazolin, and zone. After 6 weeks, we come to CST, which is cephalexin, Septran, trimethoprim, sulfamethoxazole, and tetracycline group. And this will be an important slide in CST. So it is carried out usually with oral antibiotics. It's a combination of tetracycline with rifampicin. Mind you, rifampicin is never used as a monotherapy. Tetracycline with cotrimoxazole is commonly used because it has the least adverse effects. Monotherapy with beta-lactam or tetracycline can be considered. Intravenous dalbavancin, this is what we were talking about this morning. That is because of a long-term, drug-eluting or persistent blood levels, and it is used once per week or once in 2 weeks. Zone or ertapenem can be used subcutaneously. So these two are newer antibiotic regime that we can be used. IV antibiotics, there is no long-term data or long-term usage of IV antibiotics, especially if we are using them daily. And there is no relationship of quinolones and successful treatment even gram-negative bacilli. So predictors of success, 75% at 2 years, and 5 years success rate is 50%. Success rate in total knees is 55%, whereas in hips, as we have mentioned, the success rates are a little higher, especially at 50 months. Duration of antibiotics, rheumatoid arthritis, and primary organism that is isolated. These are the 3 most predictive factors of success in chronic suppressive therapy. Culture negative PGIs, of course, it's a problem. So they have got 3 times higher hazard risk as compared to staphylococcal infection. Predictors of failures, other than gram-positive cocci, anything that we grow, maybe fungi, gram-negative culture, or negative cultures themselves are predictors of failure. Prosthesis in the upper limbs are predated to failures. Age less than 70 years appears as a paradox, but most of the young patients are immunosuppressed and therefore they can fail CST. Non-adherence to treatment amounts to 24% and resistance or growth of a new bug is 12%. Appearance of an unsuspected organism can occur in 20%, and a median follow-up for a failure or a death event is almost 25 months, that is 2.5 years. Adverse events, they occur in 26.8% patients. Majority of them are gastrointestinal and cutaneous presentations. Mind you, CST has to be suspended in only 5.6%. Okay, and in 15% they require a change of antibiotics if they see any adverse reaction. So they can be given for a longer time. Diarrhea due to non-clostridial difficile or pancytopenia, dizziness, memory loss, thrush, pruritus are common symptoms or adverse effects. And only 1% do we see Clostridium difficile infection. So C. difficile infections are very, very rare. So I thank you for your patient hearing.